Assalamu alaikum. Good morning, everyone. Today I am going to give a brief talk on approach to neuropathy. So, in this topic, I am not going to emphasize or describe much in detail about the usual peripheral neuropathy we come across, but I am trying to more focus on other forms of peripheral neuropathies, which we don't diagnose usually, and we come to overlook them and we used to miss many a times. So at least after listening to this topic, we will be at least diagnose a couple of those cases, and certainly will be referring those cases to the neurologist on time. So to introduce to my topic, what is peripheral nervous system? So we all know that the central nervous system is the brain and spinal cord. So the peripheral nervous system is the nerves which connect this central nervous system to the end organs or peripheral organs. So this is communication between the central nervous system, that is brain and spinal cord, and all other body parts. So neuropathy refers to many conditions which affect these peripheral nerves. So as the name indicates, the diabetic neuropathy means the peripheral neuropathy happening in patients with diabetes because of the diabetes itself. So this is the epidemiological data, where we know that diabetes is a very commonly seen disorder. Almost 42.5 crores of people have been affected presently worldwide, and almost 7.3 crores in India. Correct me if I am wrong, because I have taken this data from one of the study, because I know there are many experts presently in the diabetes sitting in the room. So by 2050, it's been said that 1/3 of the world population will be affected with diabetes. So we know that this is a major burden in future, and why we have chosen this diabetes neuropathy topic is approximately 50% of the people with diabetes will eventually develop diabetic neuropathy. Being so common, it is our basic need to understand diabetic neuropathy. So it is to help the people suffering with diabetes who are having diabetic neuropathy. So diabetic neuropathy, the prevalence is the same in both type 1 and type 2 diabetes. It is majorly related to the poor glycemic control. So almost 75% of these diabetic neuropathies are distal symmetrical polyneuropathies, which I said, the usual peripheral neuropathy which we commonly see. Other forms, why there is a necessity to understand the other forms of neuropathy are because the etiologies may be overlapping with the diabetic peripheral polyneuropathy, or the etiologies may differ. Likewise, the etiology, when it differs, the treatment plan also will be different. So if we understand and diagnose these cases, at least we can provide them the treatment options which can cure the disorders. So what are these risk factors for diabetic neuropathy? So there are modifiable and non-modifiable risk factors. The red color indicates the non-modifiable types of risk factors in here. So one among them is long duration of diabetes, and then advanced age genetic phenotypes, especially voltage gated sodium channel variants and female gender. These are non-modifiable risk factors for developing diabetic neuropathy. Among the modifiable risk factors, you can see here blood pressure, poorly controlled diabetes, renal impairment, smoking and alcohol use, obesity, and other metabolic syndromes. They are modifiable risk factors. The down part of that slide is showing the risk factors for the diabetic neuropathy per se, as well as painful diabetic neuropathy. For painful diabetic neuropathy, the severity of the neuropathy itself and duration of the neuropathy itself are considered as a risk factor. So I want you to understand this slide, because this slide carries significance, and also it will help us to understand what I am trying to cover further. The first part of this slide is showing the length-dependent pattern of neuropathy. that means glove and stocking type of neuropathy. So it indicates that the neuropathy symptoms will start from the lower limb, that is feet, then it ascends up. Once it crosses the knee area, then it also affects the hand area. So we call it as glove and stocking distribution or length-dependent neuropathy. So the length-dependent neuropathy pattern is seen in diabetic polyneuropathy as well as small fiber neuropathy. Apart from that, treatment-induced diabetic acute neuropathy, which we see, these all three forms of peripheral neuropathies will have this kind of presentation. The second type of the picture, the second picture is showing the radiculoplexopathy or radiculopathy. That means it is asymmetrical involvement and it follows a radicular distribution. So this second slide is indicating a radiculoneuropathy pattern. The third picture is showing the pure, what we call it as mononeuropathy. That means the one peripheral nerve distribution it is pointing outwards. So this peripheral mononeuropathy, so this is seen in both two conditions here. One is cranial neuropathies as well as other peripheral mononeuropathy. So for example, like common perennial neuropathy, acute common perennial neuropathy, or what we call it as oculomotor neuropathy. So this type of mononeuropathy pattern is seen. Last but not the least, the fourth picture is showing the basically autonomic involvement. Here, what we call it as diabetic autonomic neuropathy. So here, it is showing the majority of those cases, diabetic autonomic neuropathy will be having either cardiac or GI involvement. So apart from whatever I have described, based on the previous picture, the classification of diabetic neuropathy also varies based on the onset. Here, when it is acute in onset, it happens in mononeuropathies as well as treatment-induced neuropathy of diabetes. Whereas subacute involvement is seen in radiculoplexopathies or radiculopathies, and chronic involvement is seen in the typical diabetic symmetrical polyneuropathy or small fiber neuropathy, autonomic neuropathy. Apart from that, it is also seen in entrapment neuropathy and CADP. So based on the etiology, the classification of diabetic neuropathies. So this slide is also important because if we know the etiology, we can appropriately treat them with the suitable medication. So among these etiological classification, the first one is the metabolic or hypoxic or macrovascular etiology, which is the explanation for the diabetic polyneuropathy as well as small fiber neuropathy and diabetic autonomic neuropathy. Inflammatory etiology is seen in plexopathies as well as probably mononeuropathies. Compressive etiology like carpal tunnel syndrome is seen as you can see here, median neuropathy, ulnar neuropathy, or penile neuropathies. Apart from this, the treatment-related neuropathy, which I already mentioned, acute diabetic treatment-related neuropathy. So this is the etiological classification for these diabetic neuropathy cases. So this Erlanger-Gasser classification of peripheral nerve or nerve fiber type, if we understand this, the next, how I have categorized the peripheral neuropathies so that you can better appreciate. So here you can see, usually the peripheral nerves or the nerve fibers are classified as A alpha, A beta and A delta, apart from that C fibers. So here you can see the A alpha and A beta fibers they are myelinated, thick myelinated. Whereas the A delta fibers are thinly myelinated and C fibers are unmyelinated. So here you can see it carries significance here. When it is only large fiber, we can differentiate the large fiber versus small fiber. So if it is the neuropathy is affecting large fibers, you are going to see motor manifestations as well as posterior column manifestations like vibration abnormality, like position sense, vibration abnormalities. So, and touch abnormalities. Whereas if it is affecting the thinly myelinated fibers, we are going to, or if we are dealing with the thinly myelinated fibers or unmyelinated fibers, we are going to deal with temperature perception abnormalities and pain perception abnormalities. Whereas if it is only unmyelinated fibers which are controlling the autonomic function, though those cases will be having manifestations with respect to autonomic function. So this, if we keep in mind, then we can better appreciate. So the diabetic polyneuropathy, which I am going to cover first, is more large fiber neuropathy than small fiber. But however, it is a combination, it can be in combination as well. So what is the basic pathophysiology of diabetic polyneuropathy and small fiber neuropathy? So whenever there will be hyperglycemia, that will lead to advanced glycation end products. Apart from that, the activation of protein kinase C and hexosamine pathway, which eventually will lead to oxidative stress. Whenever there will be more glucose, that will get converted into sorbitol, which in turn uses NADPH, because of which there will be deficiency of NADPH, which eventually leads to reduced production of nitric oxide, and that causes ischemia of the peripheral nerve. So first pathophysiology is oxidative stress. Second is ischemic damage leading to axonal loss and demyelination. The third one, increase in sorbitol, which will lead to reduction in the nerve growth factors and which also will contribute to the direct neurotoxicity. So this is the basic pathophysiology behind this diabetic polyneuropathy, small fiber neuropathy. You can also say diabetic autonomic neuropathy as well. So what is diabetic polyneuropathy or diabetic symmetrical polyneuropathy? As I earlier mentioned, this is the most common form of peripheral neuropathy, which we commonly come across in our clinical practice. It occurs in approximately 30% of the people with diabetes. Diabetic neuropathy, wholesome, it affects 50% of the people, and 30% of them, that means whole diabetic population, will be affected with this diabetic symmetrical polyneuropathy. So as I said, it is the most frequent diabetic neuropathy. It is more common in type 2 diabetics. And any form of chronically elevated blood glucose will cause this or lead to this diabetic symmetrical polyneuropathy. In fact, many a times we can just see patients affected with pre-diabetic status, not in the diabetic range, like 5.7 to 6.3 range of HbA1c. Still, that can lead to this diabetic symmetrical polyneuropathy. So as I already mentioned, so this is majorly a large fiber neuropathy, but it can be a combination of large fiber and small fiber. If you can remember the Erlanger-Gasser classification of peripheral neuropathy, you can better understand based on this the clinical manifestations what the patient is going to present with. As there is resemblance between large fiber and small fiber neuropathy, I am trying to cover both these two types of peripheral neuropathy together for ease of understanding. The small fiber neuropathy, as we earlier discussed, it specifically affects the type C unmyelinated fibers as well as A delta thinly myelinated fibers. It can cause both somatic as well as autonomic symptoms, but as we know, there is a separate category, diabetic autonomic neuropathy. So the small fiber neuropathy per se covers the somatic symptoms originating because of this small fiber involvement. So it is also considered as a precursor, or what I can say, it precedes the damage to large fibers in patients with diabetic polyneuropathy. Henceforth, we can say that the small fiber neuropathy, if we diagnose, it can be at least early detection of what I can say the diabetic polyneuropathy. So what are the clinical features of diabetic polyneuropathy? As I already mentioned, it is going to affect the large fibers. So that means it is going to have motor manifestations as well as the large fiber affected symptoms, which includes dull pain, abnormalities in position sense, that means imbalance, and also reduction in the sensation. But the important thing here is it follows a link-dependent manner. So it starts in the feet, then it ascends up, then it affects the hand. So there is a classification given here for this diabetic polyneuropathy, which is possible, probable, confirm, or definitive. So here, if there are only signs or symptoms pertaining to the large fiber, we call it as possible. If both the combination symptoms and signs are there, then it is probable, and it also affect if it is also having on electrophysiological testing, the nerve conduction study abnormalities are there, then we call it as definitive. Sometimes, without having clinical features, because whenever diabetic patient comes, after a couple of years, we start to do some screening tests. One among them, practiced by some clinicians, is nerve conduction study. So we can pick nerve conduction study abnormalities in them without having clinical features. What we call it as subclinical diabetic polyneuropathy. So as I said, what are the clinical features of? As I said, we are going to cover both the topics together, the large fiber and small fiber. So now the small fiber symptoms are, because we know it is affecting small fibers only, which are concerned with temperature perception and pain. So the symptoms are accordingly pain and temperature related abnormal symptoms. So burning feet, change in the pain pattern, the allodynia, cold feet, and also autonomic features like affecting the sweat in the feet. On examination, that is, the signs which were seen, which we see in small fiber neuropathy, are only change in pain and temperature perception, and there will not be any other neurological examination abnormality. The classification for this small fiber neuropathy also as the possible, probable, and definitive. So here there is a little difference. The either clinical features, like when they are there, the clinical features are there in a combination, we call it as possible. When there is normal nerve conduction study, that is sural nerve study, then we call it as probable. And definitive here is by doing some punch biopsy and proving that the intraepidermal nerve fiber density reduction. So as we discussed previously, so the clinical features for large and small fiber neuropathy, it depends on like which type of nerve fiber they are affecting. So when there are large fiber involvement, the type of pain here is deep-seated and aching type, and is also contains motor manifestations like weakness, wasting, and large fiber sensory manifestations like ataxia and poor balance. Whereas the small fiber neuropathies, it causes more pain, positive symptoms, and also change in the perception of temperature. The clinical examination is more evident in large fiber neuropathy, whereas it will not be so conspicuous, or it is not so evident in small fiber neuropathy. So picking the small fiber neuropathy is more a clinical diagnosis than any, what I can say, it is more a clinical diagnosis to pick up small fiber neuropathy. So coming back to the next topic, treatment principles in diabetic polyneuropathy, small fiber neuropathy. Here we should know that this large fiber neuropathy, small fiber neuropathy, autonomic neuropathy, so there is no specific treatment for those conditions. So here the basic treatment principles are establishing the realistic goals and expectations. Treatment is majorly symptomatic, and it is more for the pain management. Try to avoid polypharmacy and try to treat the lowest effective dose to begin with. Then as required, we can escalate the doses. So if the pain symptom is better, more than 6 months, then we can try to reduce the doses. When the symptoms are worsening, in spite of giving adequate doses of medication, then obviously we should look back and think that are we dealing with any other overlap condition. The treatment for this diabetic polyneuropathy and small fiber neuropathy, predominantly for the pain management, has been categorized as 3 drug categories. One is anti-epileptic drugs, predominantly sodium channel blockers or calcium channel blockers, and SNRIs, TCS, and other opioid medication. So you can see the categories which are approved by both European Federation and American Association are, as I said, the sodium channel blockers, calcium channel blockers, those are anti-epileptic drugs, tricyclic antidepressants, and SNRIs. So in isolation or in combination, they are approved medication. Okay? So the treatment protocol, what we follow for managing these cases are the diabetic painful neuropathy. The first choice of medication, it depends on the factors like affordability of the patient, side effect profile. So, as I just mentioned, we will choose one among these categories of medication, and when the symptom is not relieved at all, then we will switch to other drug category. Whereas, if we see partial response, in that context, we will try to choose the combination, keeping the previous one like anticonvulsant medication also. We'll keep that and we will add to that any further drug. So these are potential targets, apart from whatever symptomatic medication I have mentioned about. These are potential targets. Still, there are in the couple of them are in the investigation phase only, and a couple of them are presently available. So alpha lipoic acid, it acts on oxidative stress, and for the ischemic, this slide, without these add-ons, the earlier slide already we have discussed based on for the pathophysiology of the diabetic neuropathy. So here you can see like alpha lipoic acid, which we commonly prescribe for in multivitamin tablets for the diabetic neuropathy patients. It has a role for reduction in the oxidative stress, and the medication to improve the blood circulation, the topical nitric oxide, and also silastazole, phosphodiesterase inhibitor, which also has antithrombotic, antiplatelet property. The silastazole also has role in improving the ischemia in peripheral neuropathies. Apart from these, the symptomatic medication which I already mentioned, rest of these things like apart from good glucose control, which will deal with the basic problem itself, rest of those medication which I have commented on, you can see protein kinase inhibitors or aldose reductase inhibitors, they are still in the investigational phase only. Coming to the next topic, diabetic autonomic neuropathy. We know that diabetic autonomic neuropathy is basically the small fiber neuropathy, which specifically affects the autonomic function. So, what are the types of autonomic neuropathies? So, it is specific to the organ involvement. When it is cardiac involvement, is called it as cardiovascular autonomic neuropathy. When it affects the GAT, it is going to have gastroparesis or constipation alternating diarrhea, bladder level dysfunction, or sweating abnormalities, so hypoglycemic unawareness and tubular abnormalities. These are the types. So one among them I am going to choose, that is cardiovascular autonomic neuropathy, because it is important to recognize this to reduce the mortality. The pathophysiology for the diabetic autonomic neuropathy is almost the same. So I am not going much detail into this. So the same thing what we have discussed for small fiber and large fiber neuropathy. So the type of pathophysiology for autonomic neuropathy will also be the same for. Going in detail for cardiovascular autonomic neuropathy, so the prevalence is almost 20%. It carries risk of arrhythmias and myocardial ischemia. So this is the one which has high mortality risk. That means if you don't pick it on time or diagnose it on time, there may be a risk of mortality in the patient. Here, there will be primary parasympathetic, because we know parasympathetic fibers are more lengthier than the sympathetic fibers. So, the pathophysiology, we discussed that all these things, it is a length-dependent manner it will affect. So, first there will be parasympathetic involvement, followed by there will be sympathetic involvement. The symptoms which patient will describe. The first symptom or early symptoms will be decreased exercise tolerance. By the time we see the orthostatic hypotension and syncope, we can say that it is considered as advanced autonomic neuropathy. Many a times we in clinical practice see that many patients comes with dizziness. They say they have dizziness. We tend to treat them with giving some beta histine or so. So that is not going to help the patient, because the pathophysiology behind the patient's dizziness is different. It is basically orthostatic hypotension which is causing dizziness for them. The symptoms which we are treating are more vestibular related. So that's why the patient will not get relieved. Henceforth, we have to diagnose this condition properly, because as I said, it carries mortality risk. The signs which we need to elicit to diagnose this condition is elevated resting heart rate, and there is battery of what we call it as battery of test, which we clinical test, what we call it as Ewing's battery. So it contains 5 tests. 3 are parasympathetic and 2 are sympathetic. First one is the parasympathetic related heart rate variation to the standing, Valsalva mania, and also deep breathing. Apart from that, the sympathetic parameters are blood pressure fluctuations with respect to deep breathing and what we call the hand grip or standing. So clinically we should diagnose based on this battery. So if we pick at least 2 autonomic symptoms among those 5, we call it as autonomic neuropathy involvement in the Ewing's battery. So the same thing, this picture is just showing the pre-symptomatic and symptomatic phases of this autonomic involvement. The resting heart rate, resting tachycardia in the pre-symptomatic phase, and as the patient is getting advanced in autonomic involvement, there will be orthostatic hypotension. So what is the symptomatic treatment offered for this cardiovascular autonomic neuropathy? For tackling those orthostatic hypotension, we'll advise adequate hydration, that means almost 3 liters of water intake and liberal salt intake and compression stockings, and modify behavior like gradual change in position from the supine to standing position. And if required, we can introduce the orthostatic hypotension dealing medication like Frudocort, Midodrine, and specifically for Parkinson's orthostatic hypotension, we can choose Droxidopa. Then coming to treatment-induced neuropathy of diabetes. So this is basically a small fiber neuropathy happening due to rapid glycemic control. Obviously, it happens in the poor background of poor glycemic control. It is more common in type 1 diabetes. So the manifestation will be, as it is small fiber involvement, small acute severe pain or autonomic dysfunction happening after rapid glycemic control, which includes because of insulin or oral hypoglycemic drugs or strict diet control. So it is poorly responsive to analgesic medication. What we give for small fiber neuropathy, the type of medication may not help for these cases, but the good thing about this condition is it is considered as a reversible neuropathy. The pathophysiology for this treatment-induced neuropathy in diabetes, there are postulations. The first one is the microcirculation abnormalities will not get corrected with the glycemic control, so there will be discrepancy between the epineural and endoneural oxygen supply that will lead to endoneural ischemia, and also the regeneration, axonal regeneration happening because of the correction in glycemia. Those newly generated nerves will be more, what we can say, ectopically, they will produce the currents that will lead to pain, and also what we call it as immunological reaction to insulin itself. So what is the criteria for this treatment-induced neuropathy of diabetes? The baseline HbA1c should be more than 10, and there should be more than or equal to 2 reduction in the HbA1c in the 3 months, and symptoms should start within 8 weeks of this reduction in the HbA1c, and symptoms should last more than 2 weeks, and they should be severe enough to seek medical attention. It has to be treated like, as I said, small fiber neuropathy with symptomatic medication, though the response may not be as good as what we see. Apart from that, there should be gradual glycemic control rather than correcting the sugar rapidly. So next topic is mononeuropathy. We come across many people with diabetes coming to us with diplopia, sudden onset of double vision or sudden onset of foot drop. So basically the reason behind is occlusion of vasa nervosum causing central infarction of those nerves. Most commonly this mononeuropathy affects cranial nerves. Among them also most commonly it affects third cranial nerve. Likewise third, sixth, fourth and other peripheral nerves it can affect. So usually said it is self-resolving, but in specific conditions we can give SERAT trial for them. Coming to entrapment neuropathy, commonest example here is the carpal tunnel syndrome. That means paresthesias of the hand the patient comes to us, the reason behind why it is so common in diabetics is the nerve become more prone to damage because of the basic pathophysiology is what we discussed. Apart from that, the connective tissue will become more elastic, so less elastic and more stiffer and more voluminous, which will lead to compression on the nerves which are amenable or more prone to get compressed. Commonest nerves here are carpal tunnel, that median nerve at carpal tunnel, likewise ulnar nerve at cubital tunnel, and lateral cutaneous nerve of thigh at the inguinal ligament, and common peroneal nerve at fibular head. The treatment for this condition will be symptomatic using splint and decompressive surgery as required. So last topic here is lumbosacral radiculoplexopathy. Why this topic is important to understand is many a times patient comes to us with radicular pain in the lower limb. We tend to ask them to get MRI done for lumbosacral spine. And we do see, unfortunately, in those cases that they will be having some small discs. And many a times we see that those cases will be dealing with or dealt with surgical measures, but unfortunately they will not improve because the basic pathophysiology for those radicular pains are because of lumbosacral radiculoplexopathy. So symptoms here will be more pain than the usual radicular pain what we see in lumbar disc. So it is more severe and deep aching, asymmetric in onset, and it is more bothering during the night times when the patient is at rest than with activity in case of lumbosacral disc related. So weakness also will be asymmetric and it will be more proximal, and also patient, especially diabetic lumbosacral plexopathy patients, will also show significant weight loss during the symptom period. The clinical signs are asymmetric wasting and weakness in the thigh muscles and loss of ankle reflexes or knee reflexes, and sensory, there will be minimal sensory loss. So here you can see the medial thigh compartment is wasted here. So the reason behind is microvasculitis. It is basically inflammatory condition of the lumbosacral plexus which will lead to nerve ischemia and nerve damage. The good thing about this condition, though it is more symptomatic, if we diagnose this condition, it is responsive to immunotherapy. And another good thing for this condition is it is monophasic illness, and it responds very well to immunotherapy. So how to pick up this condition? When we do see there is a discrepancy in the clinical condition, that means the pain is more nocturnal, associated with wasting in the compartment muscles, and also there is no significant disc to explain that, and the patient in the background have diabetes, significant weight loss. So if there is constellation of all these symptoms are there, then we should go ahead with lumbosacral plexus study, contrast study. If that is picked, that is picking the contrast enhancement in the radicular distribution also, then we can tend to diagnose this condition appropriately, and by starting immunotherapy, we can help the patient to get relieve their symptom. Apart from that, what are the radiculoplexopathies we see? So, the same pathophysiology of immunological, that is microvasculitis, like what we have seen, the lumbosacral plexopathy, the same similar type of problem can also happen in cervical radiculoplexopathies, thoraco-abdominal neuropathy. Why this thoraco-abdominal neuropathy is important here is many times patient will come with abdominal pain. We do what all sort of investigation, but we will not find any diagnosis in them. So in those cases also, if we do the radicular contrast study, if we can able to see that there is nerve enhancement or thickening, we can treat them by giving immunological therapy whereby the patient get relief in symptoms. So the painless diabetic mononeuropathy, it mimics CIDP, but how to differentiate CIDP and this painless diabetic mononeuropathy, we can do nerve conduction study. If it is showing the axonal pattern, it favors more the painless diabetic mononeuropathy than CIDP. Thank you.
And basically, as you see, most of the clinicians, they see in and out regulated neuropathies. First, I would like to ask, common question which we face from our industry. In spite of good glycemic control, still in diabetic neuropathy progressing.
Yes, correct, sir. It is.
So,
The duration is important. The longevity of the disease is considered as a risk factor.
so that's a key point because in spite of treatment, in spite of good glycemic control, still it's progressively bad. So people land up with their maybe disabilities, they have chronic ulcers and all. So that we have to keep in mind. And also genetic factors. First, is mentioned in slide that predisposing genetic factors to diabetes, patients with diabetes. In spite of good glycemic control, they do have a underlying genetic factors which determines their progression of the disease. Thank you very much.
Thank you, Dr. Mudabbir, for an excellent presentation. My question is behind the pathophysiology of diabetes, diabetic neuropathy. Is it the fluctuating sugars that cause more damage, or because we spend higher levels of sugar that cause more damage?
I think fluctuations will cause more damage because of the, as I mentioned, there's hypoglycemia. We do see patients who have more fluctuations, landing up with diabetic neuropathy earlier than sustained high glucose levels.
Apart from that, you spoke about TINT. Is there any role of permissible hyperglycemia? Suppose if you correct the sugars rapidly, patient has dramatic symptoms. Is there any role of permissible hyperglycemia in this case?
Yeah, great point you have shown. Definitely, the sugars has to be raised, but the clear cutoff how much percentage, like how rapidly we should reduce the glucose levels, that hasn't. I mean, in the literature, whatever I have gone through, I could not able to see that. But whenever that symptom happens, like acute neuropathic symptom happens, we have to increase the glucose levels, then gradually go on reducing them.
Thank you so much.
That was a very comprehensive presentation that you had. I have just one question. I'm a neurosurgeon, so from my point of view, you mentioned about diabetic amyotrophy. Before going to an MRI or imaging studies or contrast output study that you mentioned, is there something on NCS that would give you an idea of whether it is originating from the lumbosacral plexus, or there is a surgical issue there? Or do you think that going for imaging studies and then finding not a very significant disc is more conducive to a diagnosis of diabetic amyotrophy?
Yeah, great question, sir. So basically, what we expect in peripheral neuropathies is symmetrical involvement of nerve conduction abnormalities. Okay, so though the radiculoplexus affects the proximal parts of the nerves, but definitely the NCS can pick up asymmetricity in the nerve conduction studies in both the limbs. So when there is a significant, as I said, there is a clinical description what we see in radiculoplexopathies, intolerable pain during nights. That's what we see. So many of that, not only in the radiculoplexus, the lumbosacral radiculoplexus, also in cervical. They have rapid onset of wasting, which we commonly will not come across so rapidly in case of lumbosacral discs. So the wasting will be so rapidly progressive in these cases. So that clinical background with asymmetricity in neurophysiological testing will be the gateway, or whatever the suspicious gateway, what we can say.
More reduced motor velocity compared to sensory, or
motor velocity, more motor velocity. As I mentioned, the point, the sensory symptoms, those symptoms are more when we do clinical examination, the sensory abnormalities will not be so evident.
In nerve conduction also, SICP is important, and
the proximal studies, correct. Thanks.
disproportionate to the testing more long.
Apart from that, I think it's more proximal involvement in
Correct, sir.
for this problem, I think we usually see it at a level.
I'm also talking about L2 and L3.
How long treatment we are seeing many patients have neuropathy despite the medication document. There is no relief in the symptoms, or to some extent is reduced like this. So how long do you advise the medication to continue, or when can you give a complete to the patient?
I already covered that topic, sir. In 6 months, we will, if the patient is symptom free, adequately symptom free for 6 months or so, we can try tapering those medication. But unfortunately, many a times they will come back with the symptom recurrence. So putting an endpoint for the treatment duration is very difficult in our practice.
but there is no relief. Many of the patients we see that relief is also not much. So what is the next?
Yeah, correct. So there are different ways, sir. We do see some people will treat with giving botulinum toxin the epidermal level, and also that will also practice for the post-therapeutic neurology also, because the same type of intolerable and non-remitting pain we see in those cases also. So in rare cases, Botox has the role. Correct me if I'm wrong, sir.
No more questions.
Any questions?